All right. Hi, everyone. Welcome to our August 2024 webinar series for the California Child and Adolescent Mental Health Access Portal, CalMAP, formerly we're called CAP. We have a new name now, CalMAP, but we're still the same group and offering the same service. Welcome to our first webinar of the new academic year, 2024 to 2025 today. And I see that there are people trickling in. We're gonna give it a minute or two before we start introducing our topics and presenters today. If we can have the announcement slide, that will be helpful for some information to share with our participants. Great. Thank you, May. So we have a new name, and for real-time consultation, that includes clinical guidance on how to apply what's taught in our webinars to your practice. Please continue to call us at 800-253-2103, the same number, or you can request a consult online at cal-map.org. And then for the educational offerings, including the webinar today, we'll have the new academic year and new curriculum. So now we offer live webinars, on-demand webinars, and also different types of project echoes. Here's the link to our new education offerings for year 2024 to 2025 in chat. One highlight of the new content is we also now offer monthly webinar recordings, which is called on-demand webinars. You can choose to view webinar recordings on your own time. If you don't have time during Thursday noon or lunchtime, and then you can answer questions afterwards to get CME credits. And the other housekeeping item is for today's webinar, do make sure that you either click the link in the chat or a QR code at the end of the webinar. We will show the slide that includes both the link and QR code to claim CME credits at the end of today's webinar, because now this is the only way for you to get the credits and we don't want you to lose it. And then for our sessions today, the topic is anxiety. My name is Eileen Wayne. I'm one of the child psychiatrists at CalMAP. I work on the help organizing CME and educational activities along with my colleagues, Dr. Joanne John and Dr. Lauren Schumacher. We have the topic today, and on our presenters will be Dr. Anna Swan and our very own Dr. Lauren Schumacher. For the interest of time, I'm going to go ahead and introduce our speakers today. Dr. Anna Swan is a clinical psychologist who was board certified in child and adolescent clinical psychology. Dr. Swan has over 10 years of clinical and research experiences providing evidence-based therapy for children, teen, and young adults with interfering anxiety and related concerns. She has experience working in academic, medical, primary care, university, and outpatient clinic settings. And Dr. Swan's orientation is grounded in CBT, cognitive behavioral therapy, and she is dedicated to increasing the reach of evidence-based assessments and interventions for youth anxiety and common related concerns by improving access to care and enhancing treatment outcomes. And then we have Dr. Lauren Schumacher, who is a child and adolescent psychiatrist at UCSF Bangor Children's Hospital, Oakland, and the Division of Child and Adolescent Psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences at Pritzker. She provides clinical care in the outpatient clinics and also at UCSF Bangor Children's Hospital, Oakland. She completed her bachelor's degree at Harvard University, medical school and adult psychiatry residency training at Northwestern University, and a child and adolescent psychiatry fellowship training at UCSF. For the interest of time, I'm going to go ahead and let Dr. Swan and Dr. Schumacher take away from here.
Great. So we do have some financial disclosures. I have stock holdings as a clinical director for Lumate Health, and UCSF CAP is supported by federal and state grant funding. Next slide. So our aim today is for you to come away feeling comfortable identifying and diagnosing anxiety disorders in youth, to be able to explain some cognitive and behavioral strategies to kids and their parents around addressing anxiety, and to be able to describe medication options for treating anxiety in kids and teens. Next slide. So we know that even in the best of times, youth are navigating a lot of stressors. So school and time management are some of the most common. And also, kids are navigating stressors today that most of us weren't experiencing in the same way when we were growing up. So technology is a big source of stress, social media, but it's also a wonderful source of joy and connection. A lot of youth report feeling stressed about political issues, their future, crime, violence, grades, school achievement, and just being accepted by others. Next slide. We are also not in the best of times. We are all still recovering from the COVID-19 pandemic, which affected 2.6 billion youth. And a meta-analysis of over 80,000 children and teens across the world reported that rates of anxiety and depression doubled compared to their pre-pandemic estimates. So if you're seeing increased rates of anxiety in your practice, you are definitely not alone. We also know that communities of color and under-resourced communities were disproportionately impacted by stressors that contributed to heightened anxiety and distress for many youth. And so this is why the US Preventative Task Force now recommends screening for anxiety starting at age 8. So it's no longer just the PHQ-9 and really wanting to identify depression, but also wanting to pick up on anxiety concerns and be able to intervene earlier rather than later to address this ongoing youth mental health crisis. Next slide. So what is anxiety? Anxiety is a human emotion that we all get to experience. For anybody who saw the Inside Out sequel, you know anxiety has a starring role. And there are 3 kind of components to anxiety that you can see on the screen here. The first is the feelings piece. So you can think about that fight, flight, freeze response you get when you're feeling nervous. Let's imagine I have a test coming up. I might get some butterflies in my stomach. My heart might start to beat a little bit faster. Then there's the thinking piece. So anxiety is really good at helping us look ahead to the future and spot potential problems. So we really are more likely to notice bad things that might happen when we're feeling nervous. And with this test example, I might be thinking ahead, you know what? I don't think I understand everything that's going to be tested. I'm not sure I'm going to be able to do all the problems. And then there's the behavioral piece. So with anxiety, there's usually an action urge that comes along with it to try to get rid of that anxious feeling to help us escape or avoid that potentially dangerous situation. So again, this test example, maybe this anxiety motivates me to ask my teacher for some help or to study for a little bit more to make sure that I'm prepared. So that's a really nice example of healthy adaptive anxiety. Next slide. So when does anxiety go from being a helper to being something that's problematic? Take the same test example, except this time my anxiety is at like a 7 or an 8 out of 10. I'm feeling nauseous, my mind is going blank. I'm thinking very all or nothing, very worst case. I'm going to fail. I don't know anything. I'm not going to get into a college that I want to go to. And then the action urge is I just can't even bring myself to study for this test. Every time I think about it, I feel so nauseous, I procrastinate. And maybe I miss school the next day because of my anxiety. Or I could go the opposite direction. I could spend so much time studying that I don't get any sleep the night before because of this fear of failure. And so here, the anxiety has really become a false alarm. And this is an analogy that we use all the time with families to describe how the anxiety alarm is really going off more loudly or when it doesn't need to, when the situation is actually quite safe. And oftentimes when we're introducing this to families, we might use this car alarm analogy. I want you to imagine, how many times in your life have you heard a car alarm go off? And then reflect, how many times have you actually seen someone breaking into a car? And almost certainly the number of times that alarm has gone off far exceeds the number of times it was a real problem. And that's what's happening with anxiety. That's what's happening when this alarm is going off when it doesn't need to. And when you're wondering, is anxiety kind of meeting criteria for an anxiety disorder? I always think about the 4 Ds. These are the 4 things that I'm considering, um, and this helps me to remember it. So the first D is dysfunction. And in some ways, I think this is one of the most important things to consider. So is this anxiety causing a problem in the child's life? Is it holding them back from what they want to do or what they need to do? This might be a kid who's having a hard time making or keeping friends because of their anxiety, or they're not meeting their full potential in school because they're feeling nervous to participate, or it's just causing a lot of family disruption. So you can also consider the impact on the parents and the family. Is the whole nighttime routine being disrupted because of this anxiety? The second D is distress. So we all have personal experience with anxiety. It feels uncomfortable. And so when that's happening at an intense level, it's happening often, it leads to a lot of distress. The third is duration. So how long has this anxiety been going on for? We're about to enter the new school year, so this is a really great time for this webinar. I think a lot of folks are having elevated anxiety that first week, first month around this transition point. But if anxiety has been persisting for 6 months or longer, that really does indicate it's not going to go away on its own. And then the fourth is deviation from the developmental trajectory. And I think about this in a couple ways. So one is, kids experience normal worries and fears throughout development. So this is different than what we would expect. And then the other way I think about it is just the impact of anxiety on a child's development. So you probably had that little kid in your office who has separation fears and they're nervous to go on play dates or to go on sleepovers. So they miss out on those social opportunities. They miss out on building those skills. And then now it's time for middle school and they're having a hard time making friends. And then you can fast forward to, high school. Maybe they're missing out on some important developmental milestones like driving because of their anxiety. And then sort of you can see how at that point it might be hard to launch into adulthood to get first jobs or go off to college. Next slide. So here are some quick facts. Anxiety is the most common mental health concern that youth experience. 3 in 10 meet criteria by 18. We also know that anxiety disorders tend to get overlooked, even though they cause a lot of impairment. So often these are not the kids who are having behavioral difficulties at school or at home. So they might just fly under the radar. It might be that straight A student. At the same time, we know that anxiety disorders don't go away on their own. Once anxiety is really causing a meaningful impact in a child's life, we no longer want to take a watch and wait approach because, in fact, they tend to persist into adulthood. And you can kind of think of them as a gateway disorder where untreated anxiety can lead to more anxiety over time, as well as the development of things like depression and substance use. But we have some good news. So the National Comorbidity Survey for Adolescents, which is a big survey of a nationally represented sample, reported that when providers identified and encouraged youth to seek services, they were more likely to seek services. And for the most part, this was the same across race and ethnicity, with one notable exception. So Black youth with low severity internalizing concerns, things like anxiety and depressive symptoms, were actually less likely to be identified by providers and encouraged to seek services compared to white peers with similar level concerns. And I think what this really highlights is anxiety already tends to be underdiagnosed, even though it causes significant problems, and Black youth might be at particular risk of not being identified. And so that's why we're all here, because we know the positive impact of early identification and successful intervention, and primary care is such a phenomenal setting for increasing the identification and treatment of anxiety disorders in youth. Next slide. So here we just have some common types of anxiety disorders. The top three in bold are ones that we see more than the others. I'm sure you've seen them in your office. I'll also talk a little bit about the ones at the bottom, selective mutism and OCD, because I think you will also see them and you might know less about them. And then just one thing to note on this slide is with anxiety, comorbidity is really the rule rather than the exception. So it's very common for youth to meet criteria for multiple anxiety disorders at the same time, or for how their anxiety presents to change over the course of development. So again, you might think of that little kid who has more separation fears. They move into middle school. It turns into more social anxiety. And then as they're progressing to high school and having more worries about their future, it looks more like generalized anxiety. So sometimes it is just kind of a big ball of, ball of anxiety here. Next slide. So I'm going to start with separation anxiety. On these slides, we also have some photos of celebrities to really normalize just how common interfering anxiety is. And when working with families, I think a lot of times the kids and their parents enjoy hearing about folks who are doing great, following their dreams, and dealt with very similar concerns to what they're experiencing. So with separation anxiety disorder, the key feature here is the child is feeling very worried and scared to be away from their parents. And typically, they're worried that something bad is going to happen to them when they're separated, like they're going to get kidnapped, or something bad is going to happen to their parents, like they're going to get in a car crash or never come back. As you might expect, we tend to see this more in younger kids. And you probably see this a lot in your offices showing up as kids who are having tummy aches, headaches around points of separation. They're having a difficult time going to school or falling asleep on their own. They might be missing days of school as well because of their separation fears. Next slide. Generalized anxiety disorder. So here, when you think about GAD, think about worry. Worry that is excessive and uncontrollable about everyday things. School, perfectionism, making mistakes, schedules, health, safety, stuff going on in the world. We tend to see GAD more often in adolescents than in younger children. And then the other key feature of GAD, in addition to the excessive worry, are the physical symptoms. So in kids, you need to have at least one physical symptom that happens when worried. This can be everything from feeling restless, being really tired all the time, trouble focusing. So that's an important differential with ADHD. Irritability, that's an important differential with depressive symptoms, muscle tension, and sleep disturbance. So a lot of times, kids will be really, really busy throughout their day, and then it's time to fall asleep at night, and that's where their worries will really come alive and make it very hard for them to fall asleep at night. Next slide. Social anxiety disorder. So here the key feature is fear of evaluation in social situations. Am I going to do something dumb? Am I going to be embarrassed? Are people going to laugh at me? How are other people perceiving me? And there are two kind of umbrella categories for social anxiety. One is in more performance situations, things like giving a presentation, a theatrical performance, a sports performance. The second is unstructured social situations, things like talking to new people, going to parties, hanging out with friends, assertiveness. And so you can have social anxiety disorder if you are only nervous in one of those two umbrella categories. Often it's both. Again, as you might expect, we see this more in adolescence as kids are orienting more toward their peers and caring more what their peers think about them. And then sometimes youth with social anxiety also do have social skills deficits. They might have, missed out on opportunities to really build those social skills because of their anxiety. And so that's important part of treatment if that's the case. But it's not always the case. I've worked with many teens who you would never know that they had social anxiety, but they're just really internally very, very distressed. Next slide. And so here I'll share a little bit about obsessive compulsive disorder, or OCD. I think there are some like common myths and misconceptions from the media about, what OCD is. It can really vary in terms of what it looks like based on the symptom presentation. But I've included the OCD cycle on this slide so we can really walk through it together. So typically, there's a category of situations that trigger obsessions, intrusive, scary, unwanted thoughts. You might think about contamination, intrusive thoughts around dirt or germs, but it could also be lots of other different things like harm OCD, worries about, what if I do something and hurt myself or hurt a loved one? These thoughts lead to anxiety and distress, understandably. And then this leads to engaging in some sort of compulsion or behavior aimed to get rid of that scary thought. So with dirt and germs, it might be excessive washing. Or with harm OCD, it might be confessing, telling every time you have that thought, or avoiding any potential triggers, never going into the kitchen because there are knives there. And these compulsive behaviors lead to relief. You feel better when the thought goes away, but it just feeds the cycle. And so a lot of times with families, I'll give this rash analogy. So the intrusive thoughts are kind of like you have a rash, and then when you scratch it, that's like the compulsive behavior. And it feels so much better when you scratch the rash. But what does it do? It spreads the rash over time. Um, a lot of times parents and other adults won't really be as aware of the intrusive thoughts, but they'll notice the compulsive behaviors. It might look like excessive reassurance seeking or checking or other rituals. I also want to give a shout out to the International OCD Foundation, which is a phenomenal resource for providers and for families. They've got a lot of great resources on there if you want to take a deeper dive. Next slide. I also wanted to share a little bit about selective mutism. So selective mutism is when youth are able to speak freely in certain settings. Typically at home, they have no problem, talking when they're feeling comfortable. But then when they're in other situations, often at school or just out and about in the world, they are unable to speak. And this is really stemming from anxiety, this inability to speak, not from a language disorder or from autism. You can kind of think about that fear of public speaking that I think probably almost all of us have experienced some version of, where if you have to talk in front of a big crowd, your mind kind of goes blank, it's harder to get your words out, but just kind of expand that to all situations where speaking is expected. One thing I think with all anxiety disorders, being able to pick up on it earlier and being able to intervene earlier is very important, very helpful. I think that is like extra the case for selective mutism, because the longer the child is not able to speak in certain settings, the harder it gets to intervene. And so the Selective Mutism Association has some really phenomenal resources for families as well. We also do tend to see higher rates of selective mutism in immigrant and language minority children, and they have some resources in Spanish as well on the website. Next slide.
So I think assessing and looking for those different anxiety disorders can feel very challenging and sometimes overwhelming, especially in the context of a short pediatric visit. So we really encourage using assessment tools to help with screening for anxiety. There also can be very valuable for kind of tracking progress over time in response to treatment. So here's a list of freely available, commonly used rating scales for anxiety disorders. The one you're probably most familiar with is the GAD-7. Advantages of that one is that it's short, it's just 7 questions, it's pretty easy to score, you just add it all up. Downsides of it is it's kind of more geared towards teens, 13 plus, and adults. And there's just a self-rating scale, so there's not a parent rating option, and it just specifically looks at generalized anxiety. But that can be a nice option as a kind of a more general screener for teens. The other 3, the SCARED, the Spence Children's Anxiety Scale, and Preschool Scale, and the RCADS, have similar advantage and disadvantage. The big disadvantage is they're all much longer, so around 40 questions. Advantages are they have both parent and self rating scales, which can be really nice because sometimes kids with anxiety tend to minimize their symptoms. So it's nice to have that parent report as well. They also tend to, they're kind of designed for a little bit younger group. So the scared is kind of 8 to 18, the Spence children 7 to 17. And for those really young kids, the Spence preschool anxiety scale has specifically a parent rating scale for the 3 to 6 age group, which can be a nice option for those younger kids. And all three of them kind of both give you a score for overall anxiety, as well as breaking down specific anxieties like general, separation, social. And then the ARCADS is a nice option if you're concerned about depression as well, because that one checks in on anxiety symptoms, but also asks about depression symptoms. And for these ones that are longer, they all do have free scoring Excel sheets online. So if you're using them, if you search for the Excel scoring sheet, then you can just type in the answers or have an assistant type in the answers, and then it calculates the scores for you, which is an important time saver. Next slide. So then once you've identified that anxiety is a concern in a patient, what do you do? So the recommended treatment approach is to take a multimodal approach, including education of parents and youth about anxiety disorders, consultation with schools, therapy, and medication. So kind of there's these all different pieces that we like to put together to try to help youth who are dealing with anxiety. Next slide. In terms of education, it's always helpful to talk some about anxiety in the office with kids and families. Kind of both normalizing anxiety, as Dr. Swan is talking about, everyone experiences it, and then sharing kind of some of that information of there's times where it's helpful, and then for some people, there's times where there's this kind of false car alarm where it's happening too much, it's getting in the way of things, causing dysfunction, causing distress, and that's when we know it's a problem. So there's a lot of great resources online that you can direct parents and kids and teens to for more information. Coping Cat offers online CBT modules. ACAP has a parent medication guide that talks more about medication for anxiety. Project Empower has a really nice free one session online program for parents about helping youth with anxiety, cope with anxiety, and that's also available in Spanish, which is nice. And then there's a number of other resources here that you can check out. Next slide. There's also a lot of great books for both parents and youth that really talk about, basically go through different CBT strategies for how to manage anxiety. And these are, I think, great resource, especially when they're kind of waiting to get into therapy. It can kind of offer some first steps of things to start practicing on their own. Next slide. And especially for younger kids, I really like the What to Do When You Worry Too Much book. That's kind of a workbook that goes through CBT strategies that parents and kids can even start doing on their own before they're in therapy. And next slide. There's also a lot of great apps, both specifically for kind of CBT skills and some that are more specific to mindfulness. That is often can be a nice resource for teens dealing with anxiety as well. And pass it back, next slide. Then the next part of the multimodal treatment, pass it back to Dr. Swan to talk more about therapy.
Great, thanks. So I'm going to share a little bit about cognitive behavioral therapy, or CBT, for anxiety disorders. And just like there are those three components to anxiety, CBT really aims to build skills at each corner of that CBT triangle, because if you can shift one corner, the rest can shift too. So to address the feelings piece, we're working with youth and families to identify emotions, build distress tolerance skills. We work on cognitive skills to help them have a different relationship with their anxious thinking and get unstuck from some of those negative thinking patterns. And then the real key ingredient in effective CBT for anxiety is facing fears. And so helping youth develop their problem-solving skills. How do you take this really big, scary thing and break it down into smaller pieces so it feels more manageable? And then doing exposures, which is so important. I put it in green. This is really actively practicing step by step, facing fears in session and between session. A couple of other features of CBT, it's goal-oriented, skills-based, it's time-limited. We often say we want to put ourselves out of business, really aim youth and families with the skills to keep managing their anxiety on their own. Between session practice or homework is also a really key feature. So you're sort of talking about or learning something, practicing something in session, then being able to practice that in everyday life. And then also very important is having parents and families involved in the treatment, because just like anxiety will pull kids into the anxiety cycle, it also pulls parents in too. Next slide. So here's just a bit more about the C in cognitive behavioral therapy. We know that anxiety really orients us to think that more bad things are going to happen than is really the case, or to make us think that we're not going to be able to handle it. And so one of the strategies in CBT is to help youth identify what are the thoughts that are amping up their anxiety. And one strategy might be to use questions to sort of help reframe those thoughts, think about it in a different way. If I'm feeling nervous about the test, really checking the facts on, will I really fail the test or not? What usually happens? What is the worst case? How would I handle it? Thinking through the usefulness of thoughts, and also thinking through other perspectives. And so being able to ask yourself, what would I tell a friend in this situation? I found has been particularly helpful for teens. A lot of times they're a lot kinder and more realistic with their friends than they are with themselves. Next slide. And then the B in cognitive behavioral therapy really emphasizes exposures. And this is because we know there are so many reasons that a youth might be experiencing interfering anxiety. We listed all of those stressors at the start. But we also know that avoidance is the #1 thing that maintains anxiety over time. So, I've got that test, I feel nervous, I avoid, I miss school the next day. That makes me feel better in the short term, but I don't actually learn how to handle the situation. I don't actually learn that maybe it wasn't as bad as I thought it was going to be, or even if it was hard, I figured out how to get through. And so exposure therapy really aims to break that cycle by creating, again, kind of the step-by-step plan. Sometimes we call it a fear ladder or fear hierarchy, to really help youth practice doing the things that make them nervous. They can build up their bravery muscle. A lot of times when I'm explaining this to families, I'll use a vaccine analogy. So it's like you're getting a little dose of the virus, a little bit of the anxiety, by doing these exposure practices, so that when life throws anxiety-provoking situations your way, you don't get sick because you know how to handle it. And that's the real key ingredient in CBT for youth. Next slide. So on this slide, I have a depiction of sort of how anxiety can pull parents into the cycle, and sort of the journey that parents are on and kids are on. So let's say there's a class presentation that gets assigned. The child is thinking, I'm going to mess up. Everyone's going to laugh at me. The parent is thinking, my kid is going to freak out. The child is experiencing those physical symptoms of anxiety, pit in their stomach, headache, tight chest. Same for the parent. Then the child sort of says like, oh, Dad, will you please just call just this one time? And then the parent is like, okay, like just this once. Then they both feel better. Phew. They get this relief. And then can you click? But the relief is very temporary. So the child has not learned how to handle the situation of giving a presentation, and both of them have been sort of reinforced by this parental accommodation and child avoidance. Next slide. So a lot of what we're doing when we're working with parents is helping them to identify how do they tend to respond when their child is nervous, and how can they shift how they're responding in a way that really helps their child to face their fears in a supported way rather than avoid anxiety situations outright. And really helping parents to kind of connect with their values is very useful. And a lot of times when they take a step back, they realize like, wow, they're doing things that are actually quite counter to how they want to be parenting, and they're accidentally playing on anxiety's team. So here's another acronym for you, how to care for a child with anxiety. The first C stands for being a coping model. I cannot emphasize enough how helpful this is when parents model and use skills themselves to manage their own anxiety in a healthy way, because we all pick up on what we see the people around us doing. And so when you see their parent actually experiencing anxiety like they do and being able to manage it in a really adaptive, healthy way, that helps them learn how to do it. And also when parents stay calm, it helps the kid to stay calm too. The A stands for accommodate less. So in that earlier slide, it was a nice example of how a parent can be drawn in to sort of remove the demand when their child is experiencing intense anxiety. Anxiety pulls on those natural parenting instincts to protect. But when the child has a false alarm going off, it can actually, cause the parent to be falling into an overprotection trap, to be rescuing their child when they actually don't need to be rescued. And so one question I like parents to ask themselves is this accommodation helping my child take a step toward the situation, or is it helping them escape or avoid their anxiety? So calling the teacher to get out of the presentation, that's full escape. Putting an accommodation in place around, okay, maybe there is a gradual plan around doing the presentation first with a smaller group of peers, work up to doing it in front of the class. That's an accommodation that is actually more helpful for facing fears. The R stands for reward brave behavior. And so families, I think a lot of times a bunch of focus gets paid when the child is in distress and feeling really nervous, but really helping parents also celebrate and give lots of attention and praise when their child is taking these brave steps, even if they're really small. So this can be through attention, through praise, but also a more formal reward system where they're earning bravery bucks for doing brave challenges that's then cashed in for fun activities or other things. And then the E stands for empathize and normalize. So the overprotection trap, that's one trap that parents tend to fall into. The other trap is being more frustrated or punitive or dismissive. And so here, this is about not telling your child, don't feel nervous. If that were possible, they would be doing it. Not getting punitive, but instead helping them understand that you get it, and really empathizing and normalizing that others feel anxious in situations like this too. And this is a feeling that is safe and temporary. So those are just some quick tips you could share with parents. Next slide. I'm going to turn it back over to Dr. Schumacher.
So at this point, you've got your youth with anxiety, you've kind of provided some education, referred them to therapy. When do you want to think about medication? So there's kind of different scenarios when it can be especially helpful. One is if they've been doing therapy and have limited improvement. If their symptoms are especially severe, then you want to think about kind of getting medication and therapy started right away, kind of at the same time. We talk about the importance of exposures. It's really hard work for some youth. The anxiety is so intense that it really interferes with their ability to engage in therapy and exposures. So that can be a time where medication kind of is very helpful in conjunction with therapy. If there's comorbid disorders like depression that are needing medication treatment, if therapy is unavailable, or if patient and family prefer medication treatment, those are all good times to think about medication. Next slide. Some helpful guidance in thinking about this comes from the Child and Adolescent Anxiety Multimodal Study, which was an NIH-funded study looking at 7 to 17-year-olds with anxiety that were randomized into 4 groups. One was a combined treatment with an SSRI and CBT. One was SSRI alone, one CBT alone, and then a placebo drug group. And next slide. And they found that all 3 treatment groups, so therapy alone, medication, SSRI medication alone, and the combined treatment, all had significant improvements in anxiety compared to placebo. and that the combined treatment had improvements compared to medication alone or CBT alone. So any three of those approaches are a reasonable first-line choice, including medication alone. And combination treatment of therapy and medication together is our most powerful treatment for anxiety. Next slide. They continued to follow these youth over time in the CAMELS study. And they looked at their remission status kind of annually over a 4-year period. Next slide. They found that, that their initial randomized treatment modality was not a predictor of long-term remission. So if you see in the graph above, we have the, if you look at the total sample, some of them kind of had consistent remission, 48% relapsed at some point during the 4-year follow-up, and then some kind of had chronic symptoms. So really relapse was the kind of most common pattern seen. But what they did find were predictors of remission included kind of early response to treatment. So ones that had a good response to their initial treatment, regardless of which one it was. Patients who were male, younger age, had better family functioning, fewer negative life events, and no social phobia were all predictors of remission. So those are kind of all things to also especially encourage. Next slide. Another question that comes up are there kind of, what do we know about the effects of race on medication treatment for anxiety? And the shorter answer is not very much. We don't have very much data on it. The CAM study, they did try to look at this. They looked at the 44 African-American youth who were in the study compared to the 359 non-Hispanic Caucasian children who were in the study. They found overall no differences in baseline characteristics. In terms of the treatment process, African-American children attended on average fewer sessions. But race was not a significant predictor of response, remission, or relapse in response to treatment when the difference in session attendance was accounted for. So overall, kind of our sense is that I think there's more, for non-white children can be more barriers to accessing treatment, but once they are able to access treatment, that they seem to have a similar response. There was a different study that looked at multimodal treatment for OCD that found a similar pattern, that they didn't see significant differences in clinical presentation, treatment, or response. But of course, these were all kids who were already engaged in treatment at an academic medical center. So I think that access piece is especially a challenge and crucial. Next slide. So once you've decided to start medication, the first line medication treatment for youth with anxiety are SSRIs. And these are all first line options: sertraline, fluoxetine, and escitalopram. For all of them, you start kind of at a lower dose and work your way up gradually. In terms of which one to start, kind of sertraline was what was used in the CAMS trial, and that's often my go-to for starting if there's primarily concerns about anxiety. And that one doesn't have a specific FDA approval for anxiety disorders, but does for OCD. Fluoxetine tends to be the most activating, which can be helpful, especially for youth with anxiety and depression, where there's that lower energy, low motivation piece, but sometimes is a less good fit when it's more just anxiety and it's a very kind of wound up, restless kid already. Other advantages, though, is it does have the longest half-life, so it tends to have less discontinuation symptoms. And if it's a teen who's like maybe occasionally forgetting their medication, that tends to have the less impact on treatment if they're forgetting it sometimes. And then escitalopram is a nice option. It tends to be well tolerated. It has less drug-drug interactions, and actually just last year got FDA approval specifically for generalized anxiety disorder for age 7 and over. But they're all reasonable first line options. And the number needed to treat is around 3. Next slide. So with all of these, you'd kind of start at a low dose and then be checking in every 2 to 4 weeks. If they're having a good benefit, you'd continue at the minimum effective dose and then think about gradually tapering off after they've had remission for about 12 months. If they're not haven't improved or partial benefit, you want to go ahead and increase the dose. And then if they're at the max dose, think about switching to a second SSRI. And the website SwitchRx has really nice guidance on how to cross taper between different SSRIs. And then on the other hand, if they're having significant side effects that aren't improving, then you want to think about tapering off of the current medication, switching to a different SSRI as well. If you've kind of gone through 2 rounds of SSRIs, you definitely want to be thinking, please reach out to us, call CalMap. Also think about consulting psychiatry at that point as well. And think about if there's other diagnoses that may be in play that are, impacting them as well. Next slide. In terms of side effects, one of the challenges with SSRIs is that the side effects tend to appear first. So there's something they tend to experience right away and get better kind of after a week or 2 on medication as their body gets used to it. Whereas the benefit does not happen right away. You may see some benefit in the first couple of weeks, but it can take 4 to 6 weeks to see the full benefit. So there's definitely a leap of faith involved in starting SSRIs where they're going to have side effects, they're not going to feel any better. And it's only kind of if they wait out the side effects and then give it some time that they'll start to notice some benefits. So it's definitely helpful to warn them about that and, encourage if they're able to, if they're kind of mild to moderate, side effects, try to wait it out and see if they get better. If it's more severe, then stop it and start something else. Some of the most common ones are GI discomfort. It can be helpful to make sure they're taking the medication with food. If they're having headaches, make sure they're staying well hydrated, and then they can do some supportive care with like ibuprofen or acetaminophen. With sleep problems, it can be sometimes helpful to adjust the timing. So for some people, they may find that it makes it harder to sleep. They feel more, may have some insomnia. It's helpful to take it in the morning time. If they're finding it's making them feel more tired, it can be helpful to take it in the evening time. Some people don't notice an effect one way or the other. And then some people may notice a sense of restlessness or activation where they're it's harder to sit still. They're feeling more restless. If it's kind of more mild, you can wait and see if it resolves kind of after the first week as their body gets more used to it. If it was more extreme, where they're really kind of seeming more like mania, where their restlessness and the movement is more extreme, they're not sleeping, there's other symptoms concerning for mania, then you'd want to stop the medication and consult psychiatry and call CAP or CalMap. Next slide. One concern that always comes up is the black box warning. So this was issued in 2004, warning people to monitor pediatric patients receiving antidepressants for worsening depression, agitation, and suicidality. And this was based on analysis of 23 randomized controlled trials that found a slight increase, 3.8 versus 2.2, of suicidal ideation and self-injury in those treated with SSRIs who were being treated for depression. They didn't find an increased risk of suicide. And this was particularly a concern at kind of the start of the medication or during dose changes. However, it's been controversial because after this warning came out, there was a significant reduction in the number of patients receiving SSRIs, and there was actually worsening outcomes. So kind of overall, the feeling is that the benefits of treating anxiety and depression outweigh this very small risk, but this is something we warn families and parents about, as well as teens. And if this is something that they were to notice, that when they start the medication, they notice more suicidal thoughts, that would be something to let their parents know, let their prescriber know, let their therapist know, and then we'd stop the medication. Next slide. So then if after kind of 2 trials of SSRIs, there are other medications to consider for anxiety. Generally, the next step would be to try an SNRI like duloxetine or venlafaxine. Duloxetine does have FDA approval for pediatric anxiety and can be a good choice. Venlafaxine, some people find very helpful, but it also has the shortest half-life and tends to have more withdrawal and discontinuation symptoms. So it can be harder to get off of it once they're on it. After that, sometimes people think about buspirone, propranolol, mirtazapine, or hydroxyzine. Medications that we rarely use for anxiety include the tricyclic antidepressants because they tend to have a worse side effect profile, and benzodiazepines because they didn't show efficacy in trials in childhood anxiety disorders. And there's also the risk of dependency and sedation and cognitive impairment. With all these, with these later line ones, there tends to be more, not always a lot, but more data in adults and very little data in youth. So we're often kind of extrapolating from what we know in terms of adult anxiety treatment. If you're in these waters, we definitely encourage you to call CalMAP, and we're happy to support you in thinking through what to do with youth that kind of haven't responded to initial treatments. All right, next slide. So these are our references, and now we're gonna open it up to questions.
Thank you so much. Thank you so much for Dr. Swan and Dr. Schumacher for the excellent talk and teach us about both psychotropic and psychological treatment for anxiety. We have some questions via Q&A, and earlier there was a hand held up too, so I wanted to address those first. Danielle, you had your hand up during the talk, and I wanted to give you the chance to speak or put your question in chat if you could, or in Q&A. And we also have a few questions while you're posting your question, Danielle. We have other questions from Dr. Grant. Can we discuss the difference in treatment of SSRI for OCD versus depression/anxiety? The general understanding is that OCD often will require a higher dose of SSRI than anxiety or depression. So just wondering if we're also trying to treat the comorbidities.
Yeah, that's a great question. So that is a pattern we sometimes see, that OCD may require higher doses of SSRIs than anxiety or depression. But for all of them, even if you're kind of the main treatment concern is OCD, you would still start at a lower dose and gradually work your way up. So if you're, if they have anxiety, OCD, and depression, if you're seeing improvements in all of those, then you can kind of stop at the dose you're on. If it seems like maybe you're seeing some improvements in the depression piece, but the OCD piece is still persistent, then I wouldn't be surprised if you're kind of needing to continue increasing the dose. So it doesn't necessarily, we'll still take the same approach, even if there's those comorbidities there, but it's good to keep in mind that and also warn families that it may end up needing to be a higher dose. And then I think the other piece is also checking in around the therapy, because I'd say CBT for depression and anxiety all therapy is hard to find, but CBT for anxiety, depression is relatively more common than some of the more specific CBT with exposure and response prevention for OCD. So if they're, if you're seeing that pattern of, okay, we're seeing the depression, anxiety improve, but the OCD is sticking around, definitely checking in to get a sense of like, are they getting therapy actually treating the OCD as well?
I think that's a really good point, because we sort of talked about cognitive behavioral therapy for anxiety, and it does look like lots of the pieces are similar for OCD, but there is a specialty piece to it where we really are doing not just the exposure part of things, but also the response prevention part, and really wanting to be working with a therapist who's savvy and nuanced and knows how to treat OCD specifically.
Thank you for the answers to these questions. And we also have the other one that's about family history. Is there any time when you would not recommend using SSRI as a part of treatment for anxiety?
That's a great question. So I would say in terms of family history, what would make us probably most concerned is if there's kind of a family history of a first-degree relative with bipolar disorder. That would probably be when we want to be especially careful. I think it's first helpful to get a sense of how solid that bipolar diagnosis is, because it's very different if it's, the parent talking to has a confirmed diagnosis, they're in treatment with a psychiatrist, versus I feel like half the time this issue comes up, it's like you're talking with one parent and then there's like a parent who they're divorced, their other parent's not really in the picture, and they're like, oh yeah, I think they might have bipolar. I'd say, those are, I weigh those with different significance. If it's a youth where they themselves haven't had any symptoms of mania that are concerning for bipolar, I think it would still be reasonable to try an SSRI, but I would kind of warn the patient and family that, mania would be something we'd be keeping an eye out for, and probably do a little bit more close check-in as well.
Thank you. And then there's another question about, should people start their SSRI in the morning or afternoon or at bedtime?
Yeah, so generally what I will start with is whatever they're going to remember better. So if they're already taking a medication in the morning or evening, it's often easiest just to take it all at the same time. But whatever the parent and you think is going to be easiest for them to take consistently, I'll start with that. And then say they're taking, they're like, oh, I'm already taking medication for ADHD in the morning, so let's start there. But then they're like, actually, I feel like it's making me a little bit tired. Then we might switch it to evening.
Thank you. And there are two questions about comorbidities. One is anxiety with ADHD-like symptoms versus ADHD and ADHD versus ADHD or both. Should we treat with SSRI first or stimulants first?
Yeah, this can be really tricky as they both can kind of mask as each other and are both very common. So, we can certainly have youth with primarily anxiety problems that are, not getting enough sleep, are, spacing out in class because they're worrying about their test in the next class. And it can be primarily anxiety, but have some inattention. And if you think back to the GAD-7, the criteria for GAD, difficulty with concentration is one of the kind of core symptoms. So it certainly can kind of look sometimes like there's attention issues. And then on the other hand, having ADHD can be a very anxiety provoking experience. If you're, having trouble paying attention, it can be, that can be anxiety provoking. And so there can be anxiety secondary to ADHD, and they're commonly comorbid. So I think that really starts with kind of trying to piece it apart. It's helpful to get a sense of like how their attention is in situations where they're not feeling anxious, and kind of is the attention issue just in anxiety provoking situations or also other. And it also might be something that you don't fully get a sense of until you go over time.
Mm-hmm. Yeah, and then there's a follow-up question to that. If there is comorbid anxiety, ADHD, and autism, does that change how we would select the medication?
Yeah, and let me just finish in terms of the ADHD anxiety. So I'll try to figure out which is kind of what part is causing the most problems. And if there's one that's clearly more problematic, we'll start with treatment for that. So if it's like there's clearly a lot of anxiety and maybe some attention concerns, we would target the anxiety piece first. If it's like there's a lot of inattention, hyperactivity, maybe also some anxiety, kind of maybe start with the ADHD medication first, and go from there. If they seem pretty similar, I'll generally lean towards starting a stimulant first, just because that will know much faster. Within a week or two, we'll know, is it helping and are they having side effects? Whereas with the SSRI, it will take longer. So if it's kind of even, then I would start with that. And then in terms of if there's anxiety, ADHD, and autism, that is a whole nother talk. But I'd say the biggest thing that it changes is that kids with autism are more likely to have atypical reactions to medications. So they may need unusually low doses or may need unusually high doses. So for them, if we're starting an SSRI for anxiety in a kid with anxiety and autism, we tend to start at especially low doses and kind of go gradually upwards.
Thank you so much both for Dr. Swan and Dr. Schumacher for your talk and answering the questions. Thank you everyone for joining us. Please make sure to use the QR code or the link to claim your CME credits. And as we mentioned when we started today's webinar, we now have a new curriculum for webinars. So we have the diagnosis-based webinars on the first Thursdays, and then our next webinar will be on the third Thursday of the month. And then it will be on a new topic led by Dr. John and Dr. Control for common factors. Thank you again for joining us today. We'll see you in 2 weeks.
And I will also say we have upcoming webinars on ADHD, on SSRI treatment, on autism treatment. So definitely, you know, we'll dive into more details on some of those questions at those webinars.
Thank you all.